Welcome to our discussion on the systematic review comparing beta-lactam combined with azithromycin or doxycycline versus fluoroquinolones in hospitalized community-acquired pneumonia patients. This analysis is published in Open Forum Infectious Diseases by Farah et al. 2026 under the Mayo Clinic Evidence-Based Practice Research Program. Community-acquired pneumonia, CAP, is the leading infectious killer globally, with in-hospital mortality rates ranging from 4.1% to 9.6%. Over 185,000 patients were analyzed in this study, highlighting the significant burden on healthcare systems. Despite extensive treatment experience, the choice of empiric antibiotics remains crucial, with limited comparative evidence, especially for doxycycline. We examine 3 empiric regimens for non-severe community-acquired pneumonia: beta-lactam with azithromycin, the standard of care; beta-lactam with doxycycline, an alternative lacking randomized controlled trial evidence; and respiratory fluoroquinolone monotherapy. All are endorsed by American Thoracic Society, Infectious Diseases Society of America guidelines, yet direct comparisons between these regimens remain unexplored, highlighting a significant evidence gap. This study utilized a systematic review and network meta-analysis framework, adhering to preferred reporting items for systematic reviews and meta-analyses 2020 standards. Comprehensive searches covered multiple databases. The frequentist network meta-analysis approach allowed for simultaneous comparison of interventions. Eligibility focused on adults with community-acquired pneumonia, assessing outcomes like mortality and intensive care unit admission. Safety concerns included Clostridioides difficile infection and QT prolongation. Exclusions applied to studies with less than 85% eligible participants. From 1,262 initial records, 20 studies were included in the final network meta-analysis after dual reviewer screening and full-text review. The evidence base consisted of 6 randomized controlled trials with 861 participants and 14 observational studies with 185,928 participants. Risk of bias was assessed using Cochrane Risk of Bias 2 and the Newcastle-Ottawa scale, with most studies rated low to moderate risk. The network meta-analysis included 4 interventions, with beta-lactam plus azithromycin as the primary reference. Direct comparisons were available for all except beta-lactam plus doxycycline versus beta-lactam plus azithromycin. Statistical methods included random effects meta-analysis and surface under the cumulative ranking curve SUCRA scores, with no significant incoherence detected, ensuring coherence and transitivity in the analysis. 11 studies assessed in-hospital mortality across 4 treatment arms, showing no significant differences. Both direct meta-analysis and network meta-analysis found similar results. All comparisons had point estimates near the null, with confidence intervals crossing 1.0, indicating uncertainty. Moxifloxacin comparisons had particularly wide intervals due to limited studies, reflecting substantial uncertainty. The NMA found beta-lactam plus doxycycline increased 30-day mortality risk compared to beta-lactam plus azithromycin. This aligns with recent studies suggesting macrolide benefits. However, no significant differences were noted for levofloxacin comparisons. The findings highlight the need for cautious interpretation and underscore the importance of further research to clarify these outcomes. 4 studies assessed intensive care unit admission needs. No significant difference was found between beta-lactam plus doxycycline and beta-lactam plus azithromycin. However, levofloxacin showed a modestly lower risk compared to beta-lactam plus azithromycin. Only 1 study evaluated invasive mechanical ventilation, showing no significant difference. Hospital length of stay was similar across regimens, with no feasible meta-analysis. 6 studies evaluated treatment failure across regimens, showing no significant difference between beta-lactam plus doxycycline and beta-lactam plus azithromycin. The network meta-analysis suggested levofloxacin may lower failure risk compared to beta-lactam plus doxycycline. Time to clinical stability findings were inconsistent, and hospital-free days showed negligible differences. Limited data restricts actionable guidance. 6 studies found no significant difference in C. difficile infection rates across treatment arms, with very low certainty. Similarly, QT prolongation was not significantly different between beta-lactam combinations. Clinicians should consider individual cardiac risk when prescribing, especially with azithromycin, due to its known QT prolongation risk. The summary highlights key outcomes comparing beta-lactam with doxycycline or azithromycin and levofloxacin. Notably, doxycycline shows increased 30-day mortality risk, while levofloxacin reduces intensive care unit admission and treatment failure risk. However, these findings are based on low-certainty evidence, emphasizing the need for cautious interpretation. The increased 30-day mortality risk with beta-lactam and doxycycline versus azithromycin may be due to macrolides' immunomodulatory effects. Levofloxacin shows advantages in intensive care unit admission and treatment failure due to its broad spectrum. Discordance in outcomes suggests community-acquired pneumonia mortality is influenced by multiple factors beyond antibiotic choice, emphasizing the need for cautious interpretation. This analysis is the most comprehensive network meta-analysis comparing major empiric community-acquired pneumonia regimens, including doxycycline. It uses a registered protocol, dual reviewer screening, and grading of recommendations assessment, development, and evaluation-based ratings. However, limitations include lack of microbiological confirmation, low evidence certainty, and no direct randomized controlled trials comparing beta-lactam combinations, affecting confidence in outcomes. Doxycycline is a valid alternative to azithromycin for non-severe hospitalized community-acquired pneumonia, especially when azithromycin is contraindicated. However, clinicians should note a potential increase in 30-day mortality with doxycycline. Regimen selection must consider patient-specific factors. The lack of direct randomized controlled trials comparing these regimens highlights the need for further research to guide clinical practice. This network meta-analysis provides the most comprehensive evidence on empiric antibiotic regimens for hospitalized adult community-acquired pneumonia. It suggests likely equivalence across most outcomes, with exceptions: increased 30-day mortality with doxycycline, reduced intensive care unit admission risk with levofloxacin, and reduced treatment failure with levofloxacin versus doxycycline. These findings are low certainty, emphasizing therapeutic flexibility. Beta-lactam with doxycycline is a viable alternative to beta-lactam with azithromycin or fluoroquinolone monotherapy for hospitalized adults with community-acquired pneumonia. However, the evidence is low certainty. Urgent multi-center randomized controlled trials are needed to compare these regimens directly, addressing this critical evidence gap.